Assalamu alaikum, everyone. I would like to welcome all the attendees joining us for this session to the CASME Ophthalmology International Conference 2022. I would like as well to start by congratulating the Al-CASME team, Dr. Fatma, Dr. Muhammad, Dr. Nazari, and all the team for putting up this wonderful conference. Look at the themes, it's very interesting, and I think this session is one of the very exciting sessions to join, which is discussing interesting cases in the corneal refractive surgery and how to manage unhappy patients. Tonight, we are joined with a very distinguished faculty. We'll be introducing each speaker at the beginning of his topic. The theme of the session will be 7 minutes for the presentations and 4 minutes for running the questions. I believe the first speaker, Dr. Mazen Sinjab, is running late, so we will be moving him to the last speaker, and we will start with Professor Yahya Salah Mustafa from Cairo University, Chairman of Eye Care Center, who will be giving us a presentation on ICL problem. Dr. Yahya.
Thank you, Dr. Salah, and thank you, Dr. Amri and the organizing committee. It's my pleasure to share with you this interesting case of a 24-year-old female patient who underwent ICL implantation to treat myopia. She presented 1 month post-operative, not satisfied with the result. The refraction was +6 and 2.5 diopters of cylinder. Revision of her ICL calculation and the ICL that was used was similar to what was done. Slit lamp examination, sham fluke, showed an abnormal vaulting and the shallowing in the anterior chamber. As you can see in the periphery here, you can see the anterior chamber is in the periphery is shallow and it's forming like peripheral anterior synovial. So the patient was admitted for the operating theater, and this was her sham fluke image. You had an idea, I was puzzled what was the reason for this. If the ICL was correctly chosen, the power was not wrong. So I was thinking what was the problem, and suspecting that the ICL was put upside down, explaining the clinical appearance, the sham fluke image confirmed this, that the ICL was, this is a star ICL that was put upside down. So the only solution for this is to reposition the lens, and this is what I have done. I explained to the patient, I admitted her, and I had to do 2 paracenteses. And knowing that this, the ICL with its columnar nature is very, very flexible. So my plan was to flip it instead of getting it out and re-injecting it. Now I'm injecting viscoelastic behind the ICL to separate it from the clear lens, because in such cases you're worried to injure the anterior lens capsule, and you have to be careful as well for the corneal endothelium. So every maneuver has to be delicate. And a third thing in this patient that I had to do a viscodissection to separate the peripheral anterior synovial that was detected clinically beforehand. Here, I will try to use bimanual technique. First step is to deliver the haptics in the anterior chamber in front of the iris, to free it in front of the iris. It's very important to have enough viscoelastic to protect the lens and to protect the cornea. Now I'm delivering the proximal haptics into the anterior chamber. These maneuvers cannot be done. I would not recommend this for the IPCL because it's a different material, thicker and more difficult to fold in the anterior chamber. Again, viscoelastic, always use whenever needed. Carefully trying to flip it. It doesn't flip easily if I'm using single-handed. So then when it's folded like this, the cannula will be in between the 2 folds, and the other repositor will help to unfold it smoothly in the anterior chamber. Again, viscoelastic. This was the most difficult and critical step. Then what is remaining is just positioning the ICL as normally we do, flexing the haptics behind the iris. Of course, when the iris gets constricted, it makes the maneuver a little bit difficult. But this is, as you can see, the lens is gone in the proper direction and orientation, rotating it horizontally. And once I managed to put the other haptic behind the iris, I will give attention to visco-dissecting the peripheral anterior synechia, which is theoretically should not be that difficult to dissect because it was only 1 month earlier. So you go and inject viscoelastic. Of course, you can go use a gonu lens to do this, but as it was a recent operation, so I expect that the synechia are not really, there is no fibrosis, and it's easy to visco-dissect it all around. So just to remind people that although everybody knows the orientation should be that there is a hole that in the distal haptic and another hole opposite to it, diagonally opposite in the proximal haptic, and this shows you the proper orientation. So you have to be careful while injecting the lens. And the nice thing about the ICL, it unfolds very slowly in the anterior chamber. So you have to watch the hole that it is unfolding in the correct direction. If not, immediately you should correct the positioning of the lens to avoid such an nausient complication. So in conclusion, don't lose attention at any time so as to avoid this complication, and basic rules of knowing whatever you are using, whatever the lens you are using, you have to know the right way to put it. Thank you for your attention.
Thank you very much, Dr. You have a very nice case. And I think here you highlighted two things. The role of anterior segment OCT, just to look at the contour or whether we were using Scheimpflug image. The question would be for you and for the rest of the team, since we know that ICL, especially let's say in starter hands, the material is delicate, and the AC depth also plays a role. What was the AC depth in this case?
In this case, it was 3.1, I think.
Okay, but again, in your hands, Dr. Yahya, you're expert surgeon, so the folding and managing the endothelium was relatively easier for you. But the question for the others, would you approach another way to tackle this case for the other colleagues? How would you manage the case from your side? Would you take it out, re-implant it, making the wound bigger? Just because there's a risk also you damage the lens, the natural and the ICL.
Well,
go ahead, please, Dr. Yeah, Dr.
Dr. Saleh, it happens with me in the beginning, I think that 2006 or 2007, once in my hand, it's fold. When I inject, it's fold. So I rotate it as Dr. Yahya did. And from that time, I didn't face such a thing. But rotation, when you are injecting the viscoelastic, as what Dr. Yahya shows, over the lens and under the lens and over the lens, it will be easy to slip it. Once the two you are using bimanually, holding not by forceps. It's as he's shown clearly. Any forceps use, you will bite the columnar material, because as you said, that's very delicate.
Dr. Osama, you wanted to say something?
I think prevention is better than, I think when you inject it, really very, very careful. It's,
Yeah.
if you are careful, I don't think shouldn't happen really.
Yes.
And just take it slowly. When I inject,
Definitely the
always very
loading,
careful
the
about it.
loading first, and then the injection. The loading is very
But
important.
you could see it, anyway. So,
Yeah.
but really it's very tricky. Always a standard of care should be better to have two lenses anyway.
Yes.
But I think it's if flipping sometimes it's challenged, and some people recommended you winding enlarge the wound a little bit, and you could remove it and reload again. Really, that's especially if you had another lens, it's safer to do that maneuver because you had a backup lens than to flip it inside the eyes.
So,
This is
Dr.
post-operative.
So Dr.
ياسين
Yahya,
ازاي؟
أهلا وسهلا حضرتك كيف أخبارك؟ إن شاء الله كويس. You did a beautiful job. This is a masterful hand. So most people cannot do that. So it's really important that if you have the surgical competence to do it, I think it's very reasonable to do it. It saves you from creating another incision, probably added astigmatism and whatnot. But if you are beginning with these surgeries, probably taking it out may not be a bad idea. Just, eat the cost and get another lens. And basically, as Dr. Osama said, probably having a second lens. We always have two lenses shipped anyway. I had a case referred to me back in June of this past year of a resident medical doctor who was going to start his residency, and he went in for an ICL, and the same thing, and they flipped it, and he came in with corneal edema upwards of about 800, 900, and it took us a long, long time to actually detergest his cornea. Luckily, he was young, but I am sure later on in life he probably will need something. So if you have expert hands like Dr. Yahya, I think this is great and it's beautiful and elegant technique. Don't be shy to take it out if you have problems and if you don't feel comfortable, because you really may touch the lens, you may touch the cornea, and in either situation you're worse off than just taking a lens out and putting back another one.
Yeah, I agree, but also remember this was a post-operative diagnosis, not intraoperative. Intraoperatively, you can easily manipulate it, or even you can extracting. Answering Dr. Saleh, the lens, although it is thin, the center, the optic is 50 microns, the haptic is 100 microns, you can really hold it even with a McPherson. And we have got to experience this when we're removing it to do cataracts later on for these patients. You just hold that, you deliver the proximal haptic in the anterior chamber, you hold it with a forceps, McPherson forceps, just pull it. You don't need to widen the incision. Just pull it, it will come out. And again, I just want to confirm, this does not work in this way with the IPCL. Yes. IPCL is the other type. Yes. And it's widely used now, but if you need to extract it, you have to widen the incision, and you cannot manipulate it inside the anterior chamber like this.
Beautiful. Thank you, Dr. Yahya. We need to move to the next speaker, which I believe Dr. Yassin. Thanks for joining. Finally, we get to meet this virtually. It's a pleasure and honor to have you with us. And thank you for making the time. I don't know what's the time down in the US, but it's very kind of you, my dear. So this is the introduction slide. Dr. Yassin Dawood is the Associate Professor and Chair of Ophthalmology at Howard County General Hospital and Johns Hopkins Wilmer's Eyes Institute. Thank you very much for joining us. And you have 7 minutes for the presentation and 4 for the discussion after that.
Can I share the screen, please?
Yes, please. Go ahead.
So this is actually a patient who came to me. I live in Baltimore, Maryland. I work at Johns Hopkins Wilmer Eye Institute. And this is a 48-year-old who had LASIK at an outside facility 7 months ago. And since then, he's been complaining of glare, halos, blur, foreign body sensation, and on and off pain 2 to 8 out of 10. When I saw him, so 7 months after his LASIK, he was on Nevanac, which is Dipafenec 2 times a day, prednisolone acetate 2 times a day in both eyes, Restasis 2 times a day, and refresh tears as needed, which he was taking about 4 times a day. The doctor also placed him on systemic medications, which is Valtrex. We don't have a surgical, but this is more of a medical management. Ocular history, interestingly, he had a lazy eye. He's not sure which one. He has had bilateral LASIK. Now, of course, when you review the records, the patient actually vision was 20/20. So is this really true or not? Is he a poor historian or not? We're not sure. But, he had a little bit of a myopia, moderate to high myopia, -775, a little bit of astigmatism. His PEC, interestingly, was 564, 563, so that's reasonable. 4 months after his initial surgery, his LASIK, he had actually laser enhancement for this treatment because he had residual myopia and astigmatism at that time. But that vision is 20/40, and he had a little bit of lag of thalamus. That's why he's taking the artificial tears. So here he comes to me, and his visual acuity best corrected in the right eye is 20/60, and in the left eye is 20/25, and he is -3 and -250. Remember, he was -7 some, and all of a sudden, you know, his best corrected went from 20/20 to 20/60. So he has decrease in his best corrected vision, and he still has significant, I mean, most of us who think of myopia, you know, residual or progression or regression, and it doesn't happen 4 to 7 months later. You know, otherwise, you know, physical exam is fine. This is what his eye looks like. One thing that I want the audience to pay attention to, if the image is showing well, is the fact, just look at the color of the iris. So this will just give it to you if you're an experienced eye surgeon. You'll see that the color from here to here is a little bit grayish green. And all of a sudden, when, you know, and this is the flap, and it demarcates right on the flap, and here you get to see a little bit darkish hue of the iris. So that's one thing that I teach my fellows, is to look at, like, you know, in all of these LASIK patients, what's happening for these cases. Then you look in here, and if your screen is going to show, you see that there's the slit lamp beam right here, then it diverts and it becomes right here. There's a little bit of empty no man's zone in the middle. The Scheimpflug image shows you the same exact thing, that there is the flap, there is the residual stroma, and there is a little bit of darkened fluid area right in the center. So we take the pentacam and we show that the pachymetry is 528. Now the patient was 576, and you know, now it's 528. So when you actually do the calculations for 7 diopters of ablation, you should expect about like 100 some microns decrease in the thickness, and all of a sudden the patient is only 30 microns decrease. You see the same exact thing in the other eye. So the question is, why is this patient having significant residual myopia despite 2 treatments in the right eye? The haze has not improved despite months of aggressive topical steroids, 8 times, 4, 2, and then goes back to 8. And the current pachymetry is only slightly less than initial pachymetry. So if you are always faced with that and the image of the eye like this, then you're really thinking, okay, what is this? DLK, well, DLK does not happen 7 months later. It's going to happen the first 7 days or so. CTK, the same thing, the time frame, and it's going to be behaving very different. And then there's this thing called the pressure-induced stromal keratopathy, PISC. So this is actually what we are talking about in, in PISC. You will see that since the fluid is there, it's going to decrease the hue of the iris, and it's going to change the vision, change what you are seeing. Then you have infectious keratitis, which we all pretty much know what infectious keratitis looks like. And DLK, you'll see grainy, like dusty storm appearance right here. If you can see, this is actually one of the patients I saw as a fellow. And this is when you actually do a scleral scatter, that's the best way to see a DLK kind of picture. And this really is treated with aggressive steroids, and it heals within a week or 2, maximum 4 usually. So this patient, of course, what we measured was 18 and 16, with my technician, and as I was seeing the patient with the fellow. Luckily, at that time, we had a tonopen, so I said, okay, well, let's check it out. And sure enough, the pressure was 45 and 42. Because if you measure the pressure where the flap is, you're going to get a false pressure or even lowish pressure. Versus if you actually go outside the flap, so yeah, right outside the flap, with eye care or tonopen, whatever you have, then you will actually get the accurate measurement. If you are ever in doubt, really digital palpation is going to tell you if it's 42, you should be able to feel it. If it's 18, it should feel more physiologic. Now, of course, when I dilated this patient's eyes, you can see that he's already been having, he has myopia, so he has a little bit myopic crescent, a little bit papillary atrophy, but you can see the nerve. If you actually trace it all the way in this vessel right here, you can see that the patient has had cupping, and unfortunately 7 months later, the patient does have significant visual field deficit. So we took a healthy patient, no problems, had LASIK, and steroids, and that 7 months later, because unfortunately, when I reviewed the records of his doctors, there was not a single time that they checked his pressure. Not even like in the flap or not. If it's in the flap, you give them the benefit of the doubt. So sometimes as a busy refractive surgeon, you have to remember standard of care. You still have to take care of the patient and the eye. He came to me on a Friday. I stopped all his eye drops in Baltimore. I gave him latanoprostol, timolol, and brimonidine. He was on his way to Florida. By Monday, I said, you have to check your pressure, and told him what to tell them. And his pressure was 13. And he's like, oh my gosh, my vision is already much improved. But however, 8 months later, he still has persistent visual field deficit, glare, halos, and this became a legal case. So you have to be very, very careful with these cases that you mean to help the patient, but you end up hurting them. This is just characteristics of LASIK interface disorders, whether it is DLK, CTK, PISC, or infection, and the time frame. Usually if something is really happening on the later side, you probably are thinking about pressure induced rather than an inflammatory induced. Happy to take questions or hear the insight of our esteemed audience.
Perfect case. May I add something?
Of course.
It's an excellent message, really very important. I exactly do that. I measure the pressure. Everybody doing LASIK has to measure the pressure on each follow-up for these patients. But I have noticed also it's even more important in PRK patients where they use steroids for a longer period of time. And for such cases, if you miss the measuring the pressure, they will get exactly the same problem. And this should be very clear for the audience that you should, even they are young patients and they've done LASIK laser refractive procedure, they should be checked for the pressure in each follow-up. Thank you for raising this very important side-saving case.
Thank you, Dr. Yahya. So for the rest of do you check, like, let's say PRK, I actually check it right after I remove the, the bandage contact lens. Of course, we keep it on for about 3 to 4 days. About 10 days later, I check the pressure, and then a month later. Usually if it's a steroid induced, you're gonna see it really on the later side. It doesn't happen in the first day or two. For LASIK, when do you guys check the pressure typically? Let's say you've had LASIK, the patient comes to see you next day. Do you check the pressure? What machine do you use? Or do you wait until the flap is a little bit more adhered? Do you use the microkeratome or the femtosecond assisted flap? Or what is your typical practice as far as that?
For me, I use the eye care as the method to measure the pressure, and I don't measure it first day post-operative, but usually we will see the patient after 1 week. And then after 1 month, in each follow-up, we will measure it. And I use the femto laser or SBK. Usually, I'm in the range of 90 to 100 microns. So I correct the intraocular pressure also to know exactly what's the pressure.
Dr. Yassin, do you agree with me that definitely we are doing the anterior OCT, and any fluid collection in the sub flap is the cause of a high pressure? Do you agree with me with that?
I don't think that it's the fluid in the flap. I think it's the steroid response, and the fluid is misreading, actually giving you a misreading of an IOP. I'm not sure that the fluid in the flap is giving you the problem, because remember, pressure really is an intraocular problem, and the cornea is a conduit. So most patients will have, and the fluid collection in between the flap and the stroma is actually rather small. So I think the mistake that we have is we just misread the proper pressure in the eye, really the accurate pressure in the eye, if you want to call it. But really, it's the steroid that is the problem.
Yes, I do agree.
Thank you very much, Dr. Yassin. A lovely case. Dr. Safwan, just to be able to finish on time, it's your turn, my friend, Dr. Safwan Al-Bayati.
Yeah, just.
And can we put the introduction slide, please? Yeah. Beautiful. So, Dr. Safwan, Fellowship of Royal College of Physicians and Surgeons, Glasgow, and Medical Director of New Vision Center. He will be giving us a topic, interesting case presentation and we are very excited to know what you have for us today, for tonight.
Okay. So what
Dr.
we
Yasin
have
is still
here,
with us, correct?
sorry.
Go ahead,
Yeah.
Dr. Safan.
Okay, done. Just wait for me. And so what we have here, a case of lady that present to us with that radial keratitis, radial keratectomy, and she did it, I think that 1980 or 1985, I'm not sure about it, and her problem was night vision and low visual acuity. Pre-op for the right eye it was 0.4 unaided, and for the left eye was 0.3 unaided, and corrected to 0.6, but still the night vision was disturbing her in a way that she was not able to drive, and she was not able to do any activity night because of the starburst and because of the halos that she had it. Looking to her refractive and high order aberrations readings, and what we did for that, this is a summary, and that we will repeat it again after seeing what we did, is that the high order aberrations she had in the right eye, total root mean square of 2.1 diopteric equivalent, and left eye it was 2.16 diopteric equivalent, spherical aberration 1.7, and left eye 1.8, comma was 0.9, and left eye 0.98. So patient being informed that what we will do is that we will regularize the cornea, and we will redistribute the K reading on the cornea, and instead of promise her that she will be unaided by the glasses. So our aim from this treatment is to improve her visual performance and the quality of the vision. If we will look to the tangential, I like the tangential map rather than the sagittal map here in reviewing the post-refractive treatment, and we can see that the treatment that done as a radial keratotomy shows severe flattening in the center with a steepening periphery, and that's the classical. And if we will go through, that's the anterior. If we will go through the epithelial map, MS39, you can see that the central epithelial thickness was 87. So really she was suffering from what she had, and that pushed me to provide her with this treatment. So what we did is that I will show this is the total high order aberrations with the high order aberrations map for the right eye, and that was the left map, tangential, anterior, and posterior, and this is the left high order aberrations map, shows that clearly that she has a total 2.16. Now, that's and definitely I'm using the Schwinn MRs, and I don't have any financial disclosure here. This is the abrasion-free. If we will go to abrasion-free and apply the abrasion-free without treating the higher abrasions, we will consume central about 56 microns and peripheral 92 microns, but this lady will not have improve all her symptoms. So here there is an aim to reduce as much as possible the refractive outcome, or try, personally, I tried to reduce it in a way that she will be hopefully unaided, or at least with a low visual aids, means that, sorry, with a low refractive glasses. So what we did is that if we will go to the higher aberrations, adding to the treatment, then we will end up with 109 central and 126 peripheral. Now here, if we will go through directly and apply it, we will have a high refractive error. What we did is that we manipulate through our machine. We have this ability to select the most clinical significant part of the higher aberrations that we need to select. And this is the machine proposal, is not the surgeon proposal. By pressing on the depth of minimize, it will keep only the clinically significant, which highlighted here by orange and red, and it gives you a reduction from maximum ablation. And we end up with 103 and 119. Now, the difference between the periphery and central is an important issue also, because once we are exceeding 10 micron in ablation between the center and periphery, we are expecting the residual refractive error. And here we have around 15. So 100% there is a refractive error residual, and that will be in a minus. And it's very easy to discover because the peripheral is more than the central. If the central is more than the peripheral, then we will end up with hyperopic. And our aim, my concern was to keep her on a minus side, better than a positive or a hyperopic shift. So keep her on myopic shift better than hyperopic shift. And that's what we went through. We treat 1.5 as a sphere. That's an example to the right eye, 1.5 to and a 0.25 cylinder. And that was the platform for the treatment. And we end up with this for the right eye. So that shows clearly the flattening of the right eye and the anterior tangential comparing to the post-op, how this flattening, it's regularized by redistributing the K reading and treat the periphery. And that's the high order abrasions pre-op and post-op. See, we can see that the total root mean square reduced from 2.1 to 1.14. And that's the epithelial map through MS39. The thickness reduced from 87 central to 56. So, and that's for the left eye. And this is the epithelial map of the left. And that's the pre and post high order abrasions map for the left, and epithelial map pre and post. And this is again the result what we gain from 0.6 visual acuity unaided to 1 post-op aided with minus 0.75 instead of plus 0.75 minus 1 cylinder. And for the left, from 0.4 to 1 with minus 0.75, minus 0.75 cylinder 154 instead of plus 1.25 minus 1.5. Now, regarding the high order abrasions, from 2.1 right total to 1.14, 2.6 left total to 1.09. And that's again at the end without any haze. Great thanks for all. Thank you.
Thank you very much, Dr. Safwan. A very interesting case.
Yes.
And I would like to share or actually listen to the colleague. To start with, Dr. Safwan, I know you have experience with this case, but do you have more cases with a similar outcome in post RK and this platform?
Yes, Dr. Saleh. That was not the first case. So when she came to me, I asked her, so what you need? You need to be unaided? She said, no, I just need to get rid of this photopsia at night. So that's what encouraged me to go through and do my best. Because patient that's coming to me saying, no, I need to be unaided and I need to go through, no, that we cannot do it. That's first. Second is that those patients, you will face them when you will do cataract surgery for them. So you can imagine with this epithelial map, you can do whatever you will do. You will end up with a disaster after the cataract surgery. Now, if anyone thinks that he can do a LASIK for them, for example, he will end up with a disaster with a slice, a pizza slice in. Any PRK without treating the high order abrasions, you will not do anything. So it means that a low order abrasion treatment in those cases will not get rid of the symptoms, or night symptoms, especially for those patients. So the aim is to treat as much as we can from the high order abrasions. What we mean by as much as we can, the clinically significant values, and that's what we have it in our machine. It's that it gives you the possibility and it gives you the proposal that you have this value and the clinical significance of this value, we can treat it and the patient will get rid of the symptoms. And that's the beauty of the technology that we can use it in these conditions.
Beautiful. For the other colleagues, do you have a similar experience on another platform for such difficult cases with glare and halos in post-RK?
One thing.
No, I'm not that brave like Dr. Safwan. Usually these patients, many of them will not be happy after doing whatever, particularly if these are RK patients already, they have other problems, and the quality of vision and the stability of vision, they have fluctuation for the whole of their life. They have fluctuation in the vision. So it's interesting that this patient got that very good result, which is Dr. Safwan, but I don't dare to do this, unfortunately.
Dr. Yahya, well, if you are trying with them, sorry, Dr. Saleh, but if you are trying with them with the low order, because what you had is the trial of the low order abrasion. Low means that only a refractive error application and removal of epithelium manually. And this is the key, because when you are treating the transepithelial, this flattening in the center that occupied by this thickness of the epithelium will be eliminated, and that's why the patients get relief from the symptoms. Dr. Osama want to say something.
One thing concern about when they have this hyperopia, too much epithelium thickness, really there's a concern that it can regress. So the predictability over time, it's not as good when you had a very big difference in the epithelium mapping. So you worry about a few years. I'm not sure how long you had this patient follow up now.
We have the patient for the last 4 years till now, and she is very happy. And the corneal map, I can send the patient to you. She's a very nice lady. Yeah, I will send her
to Dr. Yahya. Maybe to Dr. Yahya.
No. I will send her to because we are neighbor with Osama. So I will
I
send
know the interesting about the epithelial map. Did it slowly?
That's what I'm saying. The epithelial map that I did it now. That's the new one. Is the newest one. Anyway, the issues is that when you are regularizing and redistributing the K, you don't care about the epithelium. The problem is the distributing of the K and regularizing of the cornea. The epithelium is a remodeling. So the remodel will took the shape of the stroma. If you are regularizing the stroma, 100% you will not get this flat, because how the flattening be returned back to the center? It's not returning back if you are regularizing it in a right way. The only issues is that we concern from the second case, because Saleh was very intelligent in asking how many. Yes, the few cases that we have, there was a little bit more myopic shift. Here in this case, I could have the ability to reduce the hyperopic treatment in a way that I didn't end up with the high myopia, because once you are treating a high spherical abrasion, you are as if that you are treating the hyperopic patient. So hyperopia with the spherical abrasion, it's having the same effect that inducing more myopia. Now the patient is happy, even if one of my patients, they have minus 1.5, but they are happy with the glasses, because the minus 1.5 and they are seeing 6.6 is much better than plus 1.5 on minus 1.5 and he's seeing only 0.6.
Dr. Safwan, I have to stop. I think maybe if I don't know, Dr. Mazen will join us later or not. If not, then we'll have plenty of time for discussion. But in order just to give a good chance for Dr. Osama to present his case, can we proceed, please, for Dr. Osama Jiledi presentation? Dr. Osama, consultant ophthalmologist, Moorfields Eye Hospital, Dubai. Again, interesting case presentation. Let's see what you're going to show us for tonight.
Thank you very much.
Pleasure.
Is my screen on? So basically, I had a patient who was 41 years old. She had microkeratoma LASIK about 14 years. She had injury with the pencil 1 month with corneal abrasion. The doctor that time treated her with antibiotic drops only, but she came to me after a month because complaining of blurry vision and the vision getting worse, and also photophobia. Vision was 624. So she had this epithelial growth, but also she had wrinkle in the base of the flap. So she had basically a flap dislocation. And this is the patient, she had the picture when she came to the clinic. So this is the picture exactly at the trauma. She had this gutter and you can see the fluorescence. So the flap has displaced completely and flipped back, and the doctor didn't give much notes that time. So So with the stain, you can see big micro wrinkle and epithelium growth. So they have two problems together, which is combined. So the decision you need to do surgical. So I have to lift the flap gently, just over the very gentle, because they had epithelium growth and just less trauma to the edge of the flap. So this is about a month after she had the trauma. So some people, I use the flap lifter, really. Some people use the Sinski hook, whatever way. Just very important to not to traumatize the edges. And also for the epithelium growth, you don't want to introduce much more epithelium inside and more trauma. I use the forceps to lift the flap. Some people mark the epithelium growth over the flap to see, but it's very important when you examine slit lamp, very important to clearly see the epithelium growth. Usually they tend to extend further than what you think, but always it will be examined the back of the flap, because most of the epithelium growth really is stuck in the back of the flap. So it's very gently remove this epithelium. I use the hook stick, and you can see it's very thick, really, epithelium growth in the flap. So just slowly remove it all, and from both sides. But as I mentioned, most of the epithelium growth in the back of the flap, and they just remove any at the edge of the flap. For the epithelium growth, I remove extra epithelium in the outside the flap to just give it like a barrier to avoid the epithelium growth to grow back. But if you had wrinkle alone, you don't need to do that. And just basically, because she had this wrinkle, which is really, as I mentioned, is a flap dislocated. So you don't need to remove all the epithelium. But once you had a month, you need to remove the epithelium over the wrinkle. So I remove all the epithelium over the nasal side of the flap, where's the wrinkle, and you can see the wrinkle there. It's a macro wrinkle, and the flap displaces. So, and really you need to do massaging by different way. I always use basis with the spatula, try massage it, and the dry spear is also very useful because you had more grip, and you could, so basically you manually need to stretch this flap and get rid of the wrinkles. And you could use the forceps also. And you need to be patient because that may take a few minutes really to do that. And then just I put the flap back again, align it. You don't need to do marker when the flap dislocated, by the way, because you need to look to the gather. So it's very important to look carefully, because what I do for epithelium growth, I use the pure alcohol, and sometimes 50% alcohol just in the sponge and just over the because she had both sides, in the flap side and the bed side. So the alcohol really to kill any epithelium cell remaining. Some people use the mitomycin C, but I'm not fan of that, because if I kill the epithelium by alcohol, is more stronger than don't worry about the mitomycin. That's a very slow way to kill the epithelium, I think. So I use alcohol for that reason. So just maybe almost like 20 seconds. And as I mentioned, both sides, and just I need to wash the flap very well. So just washing the flap and just align it slowly and just see if they got it or not. So just I try to smoothing the flap, massaging, and make sure that the space gutter all around the flap is equal, because you want to reposition the flap in the right position. So it should be equal distance. I had the city, that's the new city we had that time. So just try to play with it and see the effect. You don't need it in once you remove, because you could see it, but just as another tool, it can be sometimes useful for you. So once I'm happy with the flap position, but as you know, the recurrent epithelium growth is a high if you don't deal something with it. So I use the fibrin glue. So basically, I just lift the flap gently and inject the fibrin glue at the edge of the flap. I didn't do all around. Some people using all under the flap, but I don't want to disturb the visual axis area. I use to prevent the epithelium growth. So I put the fibrin glue only in the periphery of the flap. I just massaging all around, smoothing. The axis fibrin glue, that's just while massaging, just remove it. What I did for a few cases now, really, after that, I just put the tiny layer of fibrin glue, and just my idea is just to put it as a barrier, extra barrier to prevent epithelium and grow. Just if you delay epithelium, you delayed a few days extra not to go inside the gutter, that I think will help extra to prevent this, what they call epithelium growth, which can be a nuisance. And the end of the day, and the end of the surgery, just use, I put the contact lens. So this is just to see that's the reposition of flap, no missing epithelial growth. But as I mentioned, if you carefully, you should able to see if there's any piece of epithelial growth lifted. And the end of the procedure, just I use dexamethasone and Vigamox. And this is 1 month after the procedure. She had very faint hairs in that area, and there's no recurrent epithelial growth. The patient is very happy. This is 3 months and vision 6.6. So basically, post-LASIK flap wrinkle, it can happen primary, as especially if you hydrate the flap. So be careful not to overhydrate the flap. It's more common in nasal flap. It's better to use femtosecond laser because it's more common with microkeratome. But remember, if you had the trauma to the edge of the flap, it can displace it even many years. So it's very, and that's if you had epithelial growth, it can even, if you don't treat it, it can cause melting the flap. So it's very important when you had a case like this, you need to be properly managed. It's better by someone who's deal with laser surgery. I think fibrin glue is very good way to help. The other option, you could do suture. I think it's, I'm not sure if the time allowed. If you had, we can discuss, by the way, if you want another option, you could put a suture after the same thing. This is another patient who had it after 3 months from the procedure. He came to me, that's a long time ago, by the way. So basically it's same, it's just he had wrinkle, he doesn't have epithelial growth. So after lifting the flap, for the wrinkle alone, if you just in the periphery, sometimes people using hydration, just pure water to hydrate the flap if it's difficult to get the wrinkle. But this one I decided that time just put the suture to prevent, to stretch the wrinkle, but at the same time prevent any epithelial growth at the same time. The problem with the suture, sometimes it's just you need to be careful not over tight the stitch because that will cause wrinkle on top of what you had. So you don't need to over tight, just you need a good tension. And usually if you put the suture, leave it for a month and then remove it. And you need to bury the knot in the residual side, not in the flap area. So when you remove it, you don't want to lift the flap by removing the suture. And the same thing, just put a contact lens. And thank you very much.
Again, thank you very much, Dr. Osama. A very lovely case. So here actually, before we start the discussion, I want to confirm, do we have with the AV team, is Dr. Mazen Sinjab joining us?
No, sir.
Okay, so that means we have plenty of time to discuss and to review the cases that was shown tonight. So we'll start from Dr. Osama. I think Dr. Osama, you showed 2 things. And sorry?
Go ahead, please.
Okay. Osama has 2 things in this case. You showed the case with flap displacement and epithelial ingrowth and how you manage it. And you discussed 2 options as well between the sutures and the human fibrin glue. Now, just to start the discussion, for the colleagues, would you have approached this case differently?
Yes, Dr. Saleh. First of all, Dr. Osama presenting in a very nice case and a very nice approach. But before that, few cases that they are coming with the fold. The first issues that what I'm personally doing is that asking this patient how he's sleeping. Ask this patient personally, what's the approach of his sleeping? Most of them, they are sleeping, especially those that they did, as Osama said, on the microkeratome, they are sleeping on their arm. So they are sleeping in this way. So their eyes is on their arm. And I had one patient that done by one of our colleagues, and with the wrinkles and epithelial ingrowth, and they tried 3 times. And the fourth is transferred to do cross-linking, because cross-linking, as you know, that it can kill all the epithelial cells. So simply one question, how you are sleeping? He's sleeping on his face in this way, Dr. Saleh. This is 2 fists and this way. So, and sometimes on one, and that's the eye that have wrinkles in. So it's a very simple, before going to any approach, because this is the main issues to create stria, whether it's a micro or macro or fold, and then end up with the track that epithelial can pass through, and 100% it's a persistent, because daily he is sleeping 6 hours, 5 hours on that side.
Very clear, Dr. Osama. So your point here is to start. Of course, this doesn't apply to this case because this was a trauma, but you are teaching the other, let's say, guiding the others that to approach or to look at the other etiology. That's fair. But would you have done something different in the management before we come to you, Dr.
So the glue is not for me. I didn't use a glue. I used the alcohol and removed and then flattening the stria with removal of the epithelium, just like what's done, and then prevent the cause, and that's all. I didn't use a glue, and I'm not using the glue. But I feel that when you are preventing the cause, 100% will be returned back flat.
Do you mark the epithelium?
Yes, I mark, and that was the second question for Sam. Why you didn't mark the epithelium and flap before lifting it?
Because I've seen it very well. I know where is it. So that's, you don't need to. But I told you can do it. But I examined slit lamp. I precisely know where is it. And usually, by the way, even your marker is usually epithelium extended even further than what you
will lose it. Yeah.
So just still the same.
I'm putting a pin by a needle just to put 2 mark by needle, so in a way that I can know that this is the site where I return back the flap to it.
Dr. Yahya, sorry I interrupted you.
No, thank you, Dr. Osama. Just want to check something in your case. I saw the epithelial growth was towards the nasal side, and probably it has been there for a long time because it's not related. Yeah, it seems it's not related to the trauma because it's very soon for the epithelial growth to go that it looks that appearance.
Dr. Yahya, the pictures flipped from the video, other side, okay? The picture you had is flipped. If you see the picture different than the video, is the picture is reversed. So the epithelium from the temporal side, but the flap wrinkle in the nasal side, okay? Where's nasal flap? Here's nasal flap.
Okay, so I want to comment. So you managed 2 problems: displaced wrinkled flap and the epithelial engrossed. The wrinkled flaps, for me, until probably up to 3 weeks or 4 weeks, 1 month, I never remove the epithelium. For the first 2 weeks, I will use only BSS. Later on, I will use distilled water. And the key, there are 2 things that are key. Just after lifting the flap, I'm talking about correcting the wrinkles. Lifting the flap, I mark where the edges are of the flap to reposition it. And I lift it and put it back. And then I keep like 2 minutes or 3 minutes just wetting the cornea. And then with a sponge, I massage, and I tell everybody, all my fellows, that I never expect the folds to unscroll intraoperatively. I will definitely see it perfectly next morning. I don't insist on having it. What I insist on doing it, and this is my message, is that you give time for wetting. And early on, you only need BSS, distilled water later on, because you need some edema to help you to unfold the flap. So this is one thing, and I put contact lens and I see patient next morning, almost always the wrinkles are gone. I will never see it. If you dry after you think you have flattened the wrinkles, you will see the wrinkles. But if you just give it time for wetting and see it next morning, it will be gone. In the epithelial engross, I agree with you. I've never used alcohol. I use mitomycin C. And if there is intense epithelial engross or it's for a second time, I will take sutures and I will put a contact lens.
But the mitomycin C doesn't kill it the same way like alcohol, by the way, the epithelium itself.
Yeah, I didn't. I'm not.
Alcohol is more powerful.
That's what I mean. So the problem with the mitomycin C is to prevent haze that doesn't kill the epithelium.
Yes.
Oh,
so
I removed the
epithelium.
No, but the mitomycin C,
powerful.
what you put in the mitomycin C, what you putting for? Is it to prevent haze, or you want to kill the epithelium not to come back? Because we'll not kill the epithelium as such, the mitomycin itself.
Exactly.
No, not killing the epithelium, preventing it from proliferating.
Yeah. because alcohol will wash out the any epithelial cells in. And now there is some issues.
You said alcohol 50%, and this is a very high concentration.
Yeah, but
I
shorter
think
duration.
what is
seen a
short
lot,
duration?
It's
Okay.
about 15 to 20 seconds, okay?
Yeah,
Yeah.
20 seconds.
But they reported, by the way, many people use that alcohol. Some people use pure alcohol over the, under the flap. So there's no one reported endothelium toxicity from that, by the way.
Yeah.
Okay. Let's try to summarize if you don't mind. So correct me, Dr. Osama. So in your case, you lifted the flap. You did not need to mark. You did already like a mental map to understand where is the epithelium, and then you used alcohol. In the case of Dr. Yahya, maybe he preferred the mitomycin. In your case, it was 50%, 15 to 20 seconds in terms of duration. And then you used human fibrin glue for the edges. And before that, you were stretching, you removed the epithelium on top of the stria, correct? Stretching the
that's the area, because the flap
again.
is a flipped, so the flap displaces, so the wrinkles mainly in the nasal area or the macro wrinkle. So yeah, I didn't remove, because it's a month. So in a month, I don't think you massaging alone without removing epithelium will fix that macro wrinkle itself.
Yes.
But I didn't
agree.
need to remove all the epithelium because the other epithelium flap is smooth, so I don't need to remove it.
Yeah.
I understand. Well, that
Do you
was
do
a very good
anything,
one.
Dr. Salah? You do something different if it's you.
No, I think I would have done what you have done, but it's nice to see how other colleagues are approaching things. And the good thing that these cases not like a ton of cases. So maybe you have seen 3 or 4, maybe Dr. Yahya, because Egypt, they have like a very big market. So I'm sure you have seen more cases. Now, going back to the case of Dr. Yahya, thank you, first of all, Dr. Yahya. You have highlighted as well another thing which is not very common for us here in the UAE, which is the other type of the ICL, the IPCL, correct? Or IP?
Yes.
Okay. And in your case, you recommended that we don't try the same approach for this kind of a lens, correct?
Correct, because it's PMMA lens, and people use it for different reasons. So, for example, in Egypt, and I think in different areas, even I know friends in Turkey are using it. It's cheaper and very easy to load, like a normal lens, very easy to inject and folds faster. But on the other hand, if you have a problem, it is more difficult to deal with.
I understand.
So it's a PMMA? PMMA?
So yes, polymetallic, but it's not a polymer like this.
Okay, so it's foldable.
And actually, the people get very good visual results. I'm not saying it's a bad lens. I don't use it. Very little times I've used it, but I've seen colleagues and I've seen the same problem with this type of lens, and I've seen how much difficult. It's more injurious if you try to flip it. So this technique, don't use it with this IPCL. Just enlarge the wound and get it out.
Beautiful. Dr. Safwan, last question.
Yes.
In your case, I'm not familiar with the Schwend. I use more the EX500. But in your case, you control as well the pupil size for the high order aberration correction, correct?
Yes. Now here we are talking about corneal wavefront. So we are not talking about ocular wavefront. So pupil, it's not related, or the pupil size is not related here too. So we are taking the 8 millimeter of the cornea, and you can according to your optical zone, adjust the higher abrasions optical zone. So for example, your optical zone, my optical zone was 7 because the radial keratotomy was 7. So I took the higher abrasions of the cornea, which is a corneal wavefront, to the 7. It's not an ocular, because ocular, that depend on the pupil size.
Okay, very interesting. But that's fine. Back to the same point. And then the plan is the whole plan suggested by the machine itself.
Yes, the plan you will go through and you will submit the data, and the data will be taken and analyzed by the patient, by the machine, the software, and you will ask the machine to save the tissue. And the saving tissue, it will be in the two type. I can show you 1 minute the issues.
It was 6 micron, my friend.
Aha.
So I got you. It was
I
6
think it-
micron. It was almost Dr.
Yeah,
Dr.
that's what
Sabah
I'm
referring
saying.
to the tissue
Yeah, yeah.
saving, and that was
No,
a
the
very big
save
case.
that you can save as much as you can. So the saving by taking
Yeah.
the clinical significant, because the clinical significant was high. That's why the machine is right.
It's 940, Habibi. It's 940. Thank you very much. It was a very
Most
lovely
welcome.
session. I
Thank
enjoyed
you.
it, and I learned a lot from all of you. I'm sure as well the attendees did as well. I think 940 you have to close. Thank you very much, and I wish you a very successful for the rest of the
Thank you.
event and the
Thank you,
session.
Saleh.
Thank you very
Thank you
Ma'as-salama.
very
Assalamu
much. Thank you. Bye bye. Take care.
Assalamu.
Take care. Bye bye.